Hello, dear students. Now we start with the lecture of folic acid antagonists and urinary tract antiseptics. So in the previous lecture, we talked about the fluoroquinolones and we explained their mechanism of actions and how they produce their antibacterial effects. Now, today we're going to talk about the folic acid antagonist or antifolate and the urinary tract antiseptic drugs. So since we are talking about folic acid, we have to quickly review the term folic acid. So folic acid is a coenzyme which is very important and essential in the synthesis of nucleic acid RNA and DNA, and also certain amino acids. In the absence of folate, cells cannot grow or divide because in the structure of the DNA or RNA, there's folic acid. So folic acid will lead to the synthesis of the RNA and DNA. So humans use dietary folate to synthesize the critical folate derivative, tetrahydrofolic acid. So the tetrahydrofolic acid will lead to the synthesis of DNA and RNA. We have a group of drugs called sulfonamides. Okay, they're also called sulfa drugs. They were the first antibiotics used in clinical practice. So initially, when antibiotics were discovered, these drugs were the first antibiotics to be used in clinical practice. Regarding their mechanism of action, we can say that microorganisms use the enzyme dihydropyruvate synthetase to synthesize dihydrofolic acid from the precursor molecule para-aminobenzoic acid. So sulfonamides are synthetic analogs of this PABA, para-aminobenzoic acid. So because of this structural similarity, the sulfonamides compete with PABA to inhibit the enzyme dihydrofolic acid dihydropyruvate synthetase and the formation of bacterial dihydrofolic acid. So by this illustration, we further understand the mechanism of action. Here we have the precursor of dihydrofolic acid inside the microorganism, para-aminobenzoic acid, and since sulfonamides have similar structures to the PABA, so they compete with they inhibit the synthesis of this enzyme, the function of this enzyme, dihydropyruvate synthase, which is responsible for the formation of dihydrofolic acid from para-aminobenzoic acid. So sulfonamides inhibit this enzyme, dihydropyruvate synthase. So they are considered as bacteriostatic drugs. They inhibit the growth of the bacteria. Resistance to these drugs might be due to several mechanisms. So we can say bacteria that obtain folate from their environment are naturally resistant to sulfa drugs. Some bacteria are able to get their folate from their surrounding, from the host. So in this case, the bacteria is naturally resistant from the effects of the sulfonamides. Why? Because if even the sulfa drug inhibits the enzyme responsible for the formation of folate, the bacteria will get the folate from other sources, from the external environment. But acquired resistance can rise from plasmid transfers or from random mutations, which means that when two bacterial cells join each other or attach each other, their genetic material can be transferred between the two microorganisms through plasmids. So these plasmid transfers lead to transferring the genetic material from one bacterial cell to another, or might be due to random mutations of the in the bacterial cell that leads to formation or creating resistance against the sulfonamide drugs by three mechanisms: either altered dihydropyruvate synthetase, the enzyme undergoes conformational change and changes its structure so that the drug cannot recognize it. So this is one mechanism of resistance. Another one is decreased cellular permeability to sulfa drugs. Of course, decreased permeability of the bacterial microorganism to the sulfonamides. And enhanced production of the natural substrate para-aminobenzoic acid, which means that even if the drug, at that case, when the concentration or the amount of this PABA is increased, even when this enzyme is inhibited, the excess para-aminobenzoic acid can form or can create dihydrofolic acid. So these three mechanisms are the main mechanisms of resistance to sulfonamide drugs. So organisms resistant to one member of this drug family will be resistant to all of the other drugs. Regarding the clinical uses of these drugs, they are used for simple urinary tract infections, such as we have sulfamethoxazole, and also for ocular infections, for eye infections, sulfacetamide, which is used topically as an eye drop, also for burn infections, such as silver sulfadiazine, which is available as cream or ointment, and this drug inhibits colonization of bacteria in the area of the burn. And also it's used in case of ulcerative colitis and rheumatoid arthritis, such as sulfasalazine, which is used orally, and also in the treatment of toxoplasmosis, sulfadiazine is also used. Regarding the absorption of these drugs, they are well absorbed in the small intestine, and in burn units, in patients with burn, creams of silver sulfadiazine have been effective in reducing burn-associated sepsis because they prevent colonization of bacteria. So sulfa drugs are acetylated and conjugated in the liver. The product is devoid of antibacterial activity, but retains the toxic potential to precipitate at neutral or acidic pH. This causes crystalluria, or we can say stone formation, and potential damage to the kidney. So this is one problem with these drugs, that they are more prone to crystalluria or stone formation in the kidney. Why? Because the drug is acetylated in the liver and also conjugated in the liver, but it does not, when it's metabolized or by these two processes, acetylation and conjugation, the product does not have antimicrobial activity anymore, but it retains the toxic potential to precipitate at neutral or acidic pH. So it can remain or precipitate at the pH of the fluids of the kidney, and it might lead to formation of kidney stone. So crystalluria is considered as an adverse effect of these drugs. So we can say nephrotoxicity develops as a result of crystalluria, as we said, due to the metabolism of the drug. So adequate hydration, increasing fluid intake, and alkalinizing the urine prevents the problem by reducing the concentration of the drug and promoting ionization. So this is what we explained earlier in the chapter of pharmacokinetics. We talked about ion trapping because these drugs are weak acids and so they precipitate at acidic pH. So in order to be eliminated, alkalinizing the urine will help solve the situation. Why? Because by alkalinizing the urine, the proportion of the drug that's ionized will be increased. So by this method, we reduce the reabsorption of the drug into the circulation and enhance the excretion of the drug from the kidneys. So as we said, for a drug which is a weak acid, alkalinizing the urine is the best method for enhancing the excretion of the drug. But if a drug is a weak if a weak base, on the contrary, we give an acidic drug to enhance the concentration of the drug. So this process is called ion trapping. Another side effect of these drugs is hematological disturbances. So in patients with favism or G6PD deficiency, they might lead to hemolytic anemia in these patients. The administration of these drugs might lead to hemolytic anemia in patients with G6PD deficiency. Also, it leads to granulocytopenia and thrombocytopenia. Another adverse effect of these drugs is called kernicterus. Kernicterus is bilirubin-associated brain damage, which happens in newborns. How? Because these sulfa drugs displace bilirubin from the binding sites on serum albumin. So the bilirubin, when it's detached or displaced from the albumin proteins in the plasma, they will become free. They will be free and they will become free and will be available in the circulation. So then the free bilirubin is able to pass through the blood-brain barrier in newborns. It can pass into the central nervous system. Why? Because the blood-brain barrier is not fully developed in newborns. So that's why if sulfa drugs are given to newborns, it will lead to brain damage as a result of bilirubin. And also hypersensitivity reactions are very common in these drugs, which include rashes, angioedema, which is a serious swelling of the tongue, throat, and mouth, which might lead to suffocation of the patient, or Stevens-Johnson syndrome, which is also a type of allergic reaction. It's associated with blisters, rashes, and itching, and which is a very serious condition. So if a patient is allergic to one drug of this family, of the sulfonamide, the patient is definitely allergic to all of the other drugs of the family of this family classification, the sulfonamides. For example, if the patient has sensitivity to sulfamethoxazole, we can say the patient has sensitivity to all of the other drugs of this class. Also, another adverse effect of these drugs is called drug potentiation. Sulfamethoxazole potentiates the anticoagulant effects of warfarin due to inhibition of this isozyme CYP2C9, resulting in reduced clearance of warfarin. So from this sentence, we understand that sulfamethoxazole is an enzyme inhibitor. So as we know, we have studied in the previous lectures that a drug with a property of enzyme inhibition can increase the concentration of another drug if it acts on the isozymes, which are responsible for the metabolism of warfarin. For example, in this case, if the patient is taking sulfamethoxazole as an antibiotic, and at the same time that patient is taking warfarin as an anticoagulant. So this is a responsibility of a pharmacist to advise the patient not to take both drugs at the same time, because this combination might lead to serious side effects and might result in death of the patient. Why? Because sulfamethoxazole acts as an enzyme inhibitor, and it inhibits those isozymes which are responsible for the metabolism of warfarin. So by this way, the concentration of warfarin will be increased in the serum, and the pharmacological action of or the toxic effects of the drug will be potentiated. In this case, warfarin produces anticoagulant effects, so it might lead to bleeding and hemorrhage. Regarding the contraindications of these drugs, due to the danger of kernicterus, as we said, it's brain damage due to bilirubin. These sulfa drugs should be avoided in newborns and infants less than 2 months of age, as well as pregnant women at term, because the same thing will happen, and the sulfa drug will move through the placenta to the fetus and will also produce brain damage to the fetus. Also, sulfonamides should not be given to patients receiving methenamine, which is a urinary tract antiseptic. Why? Because they can crystallize in the presence of formaldehyde produced by this agent, because methenamine will be converted to formaldehyde, and the formaldehyde can cause crystallization of the sulfonamides, which might lead to crystalluria. So the combination of methenamine with the sulfonamides are contraindicated. Trimethoprim is a member of this class, sulfonamides. It's a potent inhibitor of bacterial dihydrofolate reductase. So its mechanism of action is a selective inhibitor of this enzyme, dihydrofolate reductase. So it prevents the formation of tetrahydrofolic acid. It binds to bacterial dihydrofolate reductase more readily than it does to human dihydrofolate reductase, which accounts for the selective toxicity of the drug. So it has selectivity for the bacterial dihydrofolate reductase enzyme, not the host. So we can say that trimethoprim is a weak base, and it's trapped in the acidic, prostatic, and vaginal fluids. Okay, so as we talked about ion trapping, because it's a weak base in the fluids of vagina and prostate, because their environment is acidic, the drug will be trapped in those organs. Regarding the side effects, we have, as from the mechanism of action of trimethoprim, we can go back to this illustration. We have here the para-aminobenzoic acid. By the enzyme dihydropyruvate synthase will be converted to dihydrofolic acid, and dihydrofolic acid by the aid of dihydrofolate reductase enzyme will be converted to tetrahydrofolic acid. So from the tetrahydrofolic acid, it's the essential active form of the folic acid, which further leads to formation of DNA and RNAs. So trimethoprim acts in this step. As we said, the sulfonamides act by inhibiting the dihydropyruvate synthase, while trimethoprim acts by inhibiting dihydrofolate reductase enzyme. So regarding the adverse effects of this drug, we can say that it might lead to megaloblastic anemia, leukopenia, this is B, megaloblastic anemia, leukopenia, and granulocytopenia. And these effects can be ameliorated or overcome by supplementary folic acid. So folic acid, the deficiency of folic acid will result in megaloblastic anemia. So this drug might lead to reduction of the synthesis of folic acid, and it might cause megaloblastic anemia. But supplementation with folic acid can solve this problem. Also, trimethoprim has a potassium sparing effect. So it may cause hyperkalemia, potassium sparing, as you all know. It means that a retention of potassium or increasing the level of potassium in serum. So it may cause hyperkalemia, especially when it's used with the ACE inhibitors. Why? Because the ACE inhibitor drugs, angiotensin converting enzyme inhibitors, which are a class of antihypertensive drugs, they usually cause hyperkalemia. And if these drugs, trimethoprim, is used with this class of antihypertensive drugs, it might further increase the serum level of potassium. So it might lead to arrhythmia or other problems. So these drugs should be taken with caution in patients taking ACE inhibitors as antihypertensives. We have another drug called cotrimoxazole, which is a combination of trimethoprim plus sulfamethoxazole. A sulfonamide plus trimethoprim forms a drug which is called cotrimoxazole. The synergistic antimicrobial activity of cotrimoxazole results from its inhibition of two sequential steps in folate synthesis. So this inhibition is called sequential blockade. Why? Because sulfamethoxazole inhibits the incorporation of PABA into dihydrofolic acid precursors, and the trimethoprim prevents reduction of dihydrofolate to tetrahydrofolate. The drug combination is bactericidal against susceptible organisms. So what do you mean by synergistic antibacterial activity? When we say they have synergistic activity, it means that when both drugs are combined, their antimicrobial activity is more than the effect of each individual drug alone. So for example, the antimicrobial effect of trimethoprim equals 1, and sulfamethoxazole alone equals 1. But while these two drugs, when they are combined together, their antimicrobial activity will equal, for example, 10 or 5. How? We say the antimicrobial activity of trimethoprim alone, for example, is equal to 1. This is just an example. And sulfamethoxazole equals 1. But when we combine these two drugs, the antimicrobial activity does not equal 2. It equals more than 2. For example, equals 10, 2, 4, 6, whatever the number. But it's more than 2. Why? Because each drug acts at a specific enzyme in the cascade. So, as we said, the inhibition is called a sequential blockade. Why? Because in the sequence of the formation of the tetrahydrofolic acid, two enzymes are included. So these two enzymes, or we can go back to this illustration which we talked about previously, this one. So these two enzymes, dihydropyroid synthase and dihydrofolate reductase, these two enzymes are key enzymes in the formation of tetrahydrofolic acid. So when those two drugs are combined, trimethoprim plus a sulfonamide such as sulfamethoxazole, each drug acts at a key enzyme. So their combination will result in a synergistic effect, not an additive effect, because this combination will further decrease the formation of tetrahydrofolic acid. And it's called sequential. Why? Because as a sequence, these two enzymes following each other, the first one is dihydropyroid synthase, is inhibited by the sulfamethoxazole, which is responsible for the formation of dihydrofolic acid. And later on, the enzyme dihydrofolate reductase enzyme will be inhibited. So the tetrahydrofolic acid will be greatly inhibited when these two drugs are combined together. So as you can see from this graph, this curve, the y-axis represents the number of bacteria, and this is time. The x-axis is time. So when there's no drug, the bacterial growth will increase, okay? But here it says trimethoprim plus sulfamethoxazole together which is called cotrimoxazole, show greater inhibition of bacterial growth. So if this is bacterial growth, the black line is no drug. As you can see, when there's no drug, there's increase in bacterial growth. And we can see trimethoprim alone, still the curve is high. There's still bacterial growth. And sulfamethoxazole alone, also, there's increase in bacterial growth. But when both drugs are combined, we can see that synergistic effect of this drug, of this combination, cotrimoxazole, significantly reduces the or inhibits the growth of bacteria. Okay. So regarding the clinical uses of this drug, we can say it's used in prostate and urinary tract infections. And also it's used in respiratory tract infections, gastrointestinal tract infections. Also it's used in the prophylaxis in HIV infected patients. And it's the drug of choice in prevention and treatment of pneumocystic pneumonia. And also in septicemia and meningitis caused by Listeria monocytogenes. So these are the clinical uses of this antimicrobial drug. Now we have finished the folate antagonist drugs. Now we have the urinary tract antiseptics or urinary tract antimicrobials. Urinary tract infections are one of the most common bacterial infections in the world, most commonly affecting women and elderly. So because the urethra in women is much shorter than the urethra in men, that's why the urinary tract infections, UTI, is found more frequently in women than in males. Methenamine and nitrofurantoin are used for the treatment of suppression of recurrence of bacteria due to their high efficacy against the pathogens such as Escherichia coli, and also their high concentrations in the urine. So we can say these drugs do not achieve antibacterial levels in the circulation, but because they are concentrated in the urine, microorganisms at that site can be effectively eradicated. So as we said, that these drugs have the ability to be accumulated in the urine, and also even if their serum levels are lower, their concentration in the urine will be elevated, and their antimicrobial effects are more pronounced by effectively eradicating microorganisms in the kidneys. So methenamine, as we said, methenamine and nitrofurantoin are regarded as urinary tract antiseptics. Methenamine is hydrolyzed to ammonia and formaldehyde in acidic urine. So usually methenamine is incorporated with an acidic drug in order to be hydrolyzed to ammonia and formaldehyde in the urine. Formaldehyde denatures proteins and nucleic acids of the microorganisms, resulting in bacterial cell death. So these drugs will accumulate in the acidic urine and produce formaldehyde, and formaldehyde will affect or degrade the proteins and nucleic acids of the bacteria, which results in bacterial cell death. Regarding their adverse effects, they cause gastrointestinal tract distress, and sulfonamides such as cotrimoxazole react with formaldehyde, so they must not be used concomitantly. So as we said previously, because formaldehyde will cause crystallization of the sulfonamides and will produce crystalluria or stone formation. So for this reason, sulfonamides must not be used with methenamine or even cotrimoxazole, which contains a sulfamethoxazole, a sulfonamide drug, should not be used with methenamine. And due to ammonia formation, use should be avoided in hepatic insufficiency because ammonia is formed during hydrolysis of this drug, and in hepatic impairment, this ammonia may further deteriorate the hepatic insufficiency. So this is an illustration of how methenamine is hydrolyzed, decomposed to formaldehyde and ammonia. Decomposition to formaldehyde occurs at low pH of urine. So in this pH, it will be hydrolyzed to formaldehyde, and formaldehyde will kill the bacteria by affecting its protein and nucleic acids. So this is an important or a serious contraindication in which sulfonamides should not be used with methenamine at the same time. Another drug, we have nitrofurantoin. It's considered as first-line therapy for uncomplicated cystitis, and it acts by inhibiting DNA and RNA synthesis. Okay. The adverse effects include nausea, vomiting, diarrhea, and rare complications of therapy are pulmonary fibrosis, neuropathy, and autoimmune hepatitis. So although these side effects are rare, but they should also be considered in susceptible patients. These events are observed with prolonged exposure greater than 1 month. If the drug is used for more than 30 days, these adverse effects might be seen in those patients. And also patients with impaired renal function or renal impairment should not be administered nitrofurantoin because of an increased risk of the adverse events. Thank you for listening.